Hello, my name is Kay Aubrey-Chimene, and I'm the director of Photonic Therapy Institute, your host for this Independence from Pain Summit. My guest for this session is Dr. Joel Epstein of Oral Medicine Pacific in Beverly Hills, California. Dr. Epstein is a professor and medical director of oncology dentistry at the Samuel Ocean Comprehensive Cancer Institute, the Cedars-Sinai Health System, and the City of Hope National Medical Center. Dr. Epstein also conducts a private referral practice in oral medicine, both in Beverly Hills and in Vancouver, Canada. I met Dr. Epstein in 2018 at the World Light Therapy Conference in Nice, France. It was then that he began to introduce me to the uses of light therapy and photobiomodulation for oral medicine. Since then, we have collaborated on protocols for assisting his patients to continue with in-home light therapy to treat a wide variety of dental issues, from oral mucositis to healing from surgery and facial reconstruction. Welcome, Joel. Thanks for joining me.
Yeah, good to be with you. Thank you.
So let's start at the beginning. What first got you into light therapy? Because of course your dental history far predates light therapy coming in. What introduced you to light therapy and photobiomodulation?
That's true. Thinking back years ago, there was a group of academics from Brazil that were at the Seattle Cancer Care Alliance, at that time known as Fred Hutchinson Cancer Research Center, and they had done some initial work on laser therapy for oral mucositis, which is the reaction to toxicity of some cancer therapies, specifically head and neck cancer with radiation and or chemotherapy now, but also in the bone marrow transplant program that was in Seattle. So that sort of led to initial contacts with people that had devices that were available at that time. The research, I think at that time, never actually was published, but that was my introduction. And this is quite a number of years ago. But since then, things have changed dramatically, as you know, and there's a good deal of research in certain conditions and diseases, and a lot of data on mucositis and cancer therapy is available now. And that on the basis of evidence of efficacy and safety, the use in that setting has increased, and research is continuing. The other conditions that I have utilized light therapy as an aid or an adjunct has been involving tissue healing, and you mentioned that in cancer patients of two main types. One is sort of soft tissue injury, meaning ulcers, but also hard tissue damage related to many bone cancer therapies, but also to some drugs that are used for osteoporosis. So that's in the bone necrosis field. Most of what I've done is in relation to patient care is in the oncology setting, but also in some other general oral medicine areas, and also in some very unique oral complications of some of these therapies that require improved intervention, treatment to improve outcomes, and those are areas in which I published as well. So we can talk more about those as, you know, today's conversation goes.
Sure. So going back, I'm going to start just in general dentistry.
Yeah.
When I talk to dentists today, and the only reason I talk to dentists today is because of you. and now we have other people saying to their dentists, oh, hey, you should see this. I get the impression that the overwhelming percentage of dentists now have some sort of laser or light therapy in their office. Or is that just the ones I talk to?
I think it's the ones you talk to. I think it's much more common, but I don't think it's any way universal. Most of the lasers that they will be using though are cutting lasers. They're the more high intensity. A few are into the low level laser photobiomodulation, but that's quite small in number compared to those who are using it for surgical management primarily. So they're familiar with light therapies and interventions, but in a surgical setting rather than in a wound healing or symptom management setting. But that makes them aware and understand this better.
More so than the average doctor who says, oh, don't do that. We don't know what it does, because they haven't had a chance to be introduced to it.
Correct. And
Right.
actually, interestingly, and because we're talking oncology, at least in part, radiation oncologists understand this because they deal with energy, and they understand cellular mechanisms and biology of the process. They can understand that its value, and so they're actually easier to discuss and present and plan and treat their patients than other people who say, "Oh, just light." And it's interesting. But those are the people that I think right now understand lasers best. Would be radiation therapists and radiation oncologists. Dentists from the cutting standpoint, but they understand there's other uses. And then you start to infiltrate, I guess, or move out into people that are dealing with muscle and joint symptoms. So those are physio and chiropractic people.
Sure.
And the penetration and understanding of light therapy is definitely increasing. I would say that it was more available earlier on in the chiropractic setting, but now it's very much expanding into the physical therapy setting. And so, for example, for patients with TMJ and jaw muscle or jaw joint conditions, inflammation and pain, this has utility, and that's one of the settings that, while I've not published on, it's one of the settings that the numbers of patients I treat are recommended to use the device.
I know I've spoken to a number of your clients that are patients that call in, and they're calling for TMJ issues, for jaw issues.
Right, which is basically a musculoskeletal condition like all the others. And
but it's with the mouth, so yeah. Right.
So the therapists then in those settings, some are very unfamiliar with oral, especially the physiotherapists, because they treat back and neck, for example, more than they treat TMJ.
Right.
There are people that are more specialized and more focused on, then it would be head and neck, meaning TMJ and neck, and they tend to be, they either understand and have access to light therapies, or at least understand but don't have the device. But that's the group that I'm mentioning. I think the penetration of the device and its use is really increasing.
Well, I think as we've seen more affordable products, we see more physical therapists, massage therapists, people who might not have the ability to invest in a $25,000, $35,000 laser system, or they start seeing one of the things, of course, that's growing is beds and so on in exercise spas and places to go work out. So I've gotten a number of calls from doctors, from therapists who saw it in one of those settings, and they went, oh, I could be doing this. I could be charging for this. So I thought that was an interesting growth, that it came out of sports physiology and sports medicine, or dentists, and now the regular medical facility or therapists are starting to learn more about it.
So soft tissue, muscle joint, and then nerve-based pains or neuropathies are another use. But in the dental world, I think the broadest potential application is in wound healing, as far as the general dentist population or the oral surgery practices go.
So let's go into that. How are you using it with wound healing?
Well, basically, my practice is oral medicine, and I'm a little bit of a different kind of provider. So I use it to assist and maybe stimulate, I guess would be a better term, wound healing of chronic wounds that have been there a long time. That's different than the acute wounds, say, following surgery, like tooth extraction, or following a tissue biopsy. But in all of those settings, if you can reduce the healing time, which will obviously by accelerating healing, but also suppress the pain concurrently. That's a massive potential patient advantage. And actually an office practice advantage, because if we can reduce use of oral pain relievers and opioids, that's something that is very much part of the goals in this whole thing. So I think that from the acute care provider, that's most dentists and then certainly most oral surgeons, that's actually a different model than that I play a role in. I play more a role in the chronic conditions, like, for example, ulcers following radiation therapy that haven't healed in a year or two. And these are very big challenges. That's one of the populations that with these challenging lesions, we've published a case series, and we saw healing of lesions that have been there for a year or longer in 3 weeks, and actually could visualize it weekly closing when nothing else had worked. Interestingly, for me, a group of individuals in France at a cancer center who I knew from meetings said, "Oh, that's a really great publication. We have a case that we are about to report, but we don't know if we should do it now." And I said, "No, you should, because then you have at least," and the findings are identical. A few weeks and it was resolved, and these were long-standing ulcers. And so after that they did, which is good, because now you can say there's two centers, and it just adds the potential impact, because if one person does it, there's not good control. So that was
It's going to be replicatable.
Yeah, from my point of view, even though, so in the literature, as far as I'm aware, there's the 3 cases we did. These are, again, head and neck cancer radiation patients with lesions that didn't heal. And they did 1, and they're identical in terms of weeks and in terms of the reduction in pain and then resolution. Actually, just finishing the report of those cases, because the radiation effect is permanent in the tissue, which is a reduction in blood supply, and that's part of the reason things don't heal. One patient, it recurred, and after a week we were able to close it back up after it had been present in the same location for 2 or 3 months. So it was interesting. So in essence, we replicated the impact on recovery of a chronic ulcer in patients with radiation therapy, both initially and then with a recurrence even faster.
And how often were you seeing those patients?
Well, those ones were in office at the time, and so we'd see them twice a week. And so 6-8 treatments, and it's resolved.
And 6-8, so in your office, that's a laser treatment.
Correct.
What kind of dosage are you giving?
Typically 60 seconds pulsed per point, and I think we're at around 6 joules per centimeter squared. And, so the treatment is, a few minutes.
It's not massive. They're not going in for an hour of having their head in a radiation machine. That's the beauty of it.
And potentially, obviously replicated and maybe more easily at home, and maybe even more quickly at home if it's done on a daily basis. But we don't have those data to tell us that. But potentially much easier, maybe less expensive, probably equally, but maybe more rapid effect. And of course, if you have recurrence, then you have your tool available to just manage it. So, radiation changes are permanent, and to heal a lesion like we were able to do in those settings following radiation therapy is pretty remarkable.
Now, was that red, infrared, a combination?
Combination red, infrared, yeah.
Okay.
Interestingly, most of the research in cancer therapies have been in radiation-induced acute mouth tissue damage, so mucositis. And that's now almost every treatment is a combination of radiation plus chemotherapy for advanced disease. And the complication is severe. Gets people with severe mucositis, which is almost everybody that gets treated with radiation for head and neck cancer, with or without chemotherapy, although it's worse with chemotherapy, will have need for opioid analgesics, sometimes tube feeding and artificial feeding, having pain that prevents eating and speaking, and in the worst sense, people get readmitted or admitted to hospital for pain management, and the worst complication of all this may be interruption in the radiation therapy. And when you're in the cancer world, you know that the primary goal, the prime directive, we could call it, is to complete the cancer therapy on dose and on schedule without breaks. Because you take a break in radiation therapy, for example, and there can be recovery of the cell population you're trying to kill. And so that really is the most important need. And as you know so well, then hopefully people will understand or come to know, this is one of the best documented of the cancer therapy uses for red light and infrared light. And that's prevention and or treatment of radiation mucositis. And so in those settings, what you see is pain reduction and lesion reduction and reduced inflammation. So you're really working with the obvious anti-inflammatory and analgesic effects. Coincidentally, another group of patients in cancer, and a few studies now have started to show that there may be a positive impact on saliva production, which if the major saliva glands are included in the radiation or just with chemotherapy or in autoimmune disease where the glands can be affected, then this may also act as another means of stimulating salivary gland function, meaning more saliva. And that then has all of the potential benefits of comfort, but also prevention of oral and dental disease that saliva is there to do. So there are some other aspects of management of head and neck cancer patients beyond mucositis and beyond the acute phase into the chronic phase. And what I mentioned about wound healing, those are the chronic phase patients. But what I haven't talked about is bone necrosis in cancer patients, but also in osteoporosis for people that are on the common drugs like Fosamax and Prolia and several others, is that the bone loses either cells or vascularity and becomes an at-risk site because of dental disease or even dental treatment, particularly if it's surgical, for non-healing bone. So then you end up with a condition that medically is bone necrosis or osteonecrosis. That can be long-term chronic problems and with or without pain, actually. If there was more pain, people might get treatment earlier. That would not be a bad thing, but never mind, that's just sort of a teleological argument.
That's interesting. I've never really thought about osteoporosis in the mouth.
Yeah. Well, the issue there is that the drugs go there preferentially, and the highest risk site is the mandible, the lower jaw, towards the posterior, partly, at least theoretically, this is the assumption, I guess, medical assumption, is that there's greater bone density, poorer blood flow, and a sort of a limited baseline vascular supply. So you compromise that and add some kind of trauma potentially, although not necessarily, like inflammation around a periodontally involved tooth, like inflammation around a tooth that has an abscess, like trauma from some taco chip that sort of rubs up against and injures the mucosa on the inner side of the mandible, and then it can't repair. So the problem with that is it's very chronic and it is hard to manage. There are some cases where you might go to surgery, but most cases we try to avoid because, especially with the bone problems induced by drugs, we don't know if there's a good part of the bone with a good blood supply relative to the area where the problem is because it involves everything. So it's actually kind of interesting that the bone that supports the teeth, or the alveolar bone, is really more metabolically active generally. And there's, again, theoretical arguments about, well, there's more trauma from biting and chewing and gum infections, and so it has to be more biologically active. But you lose teeth and the bone goes away. Its only job is to support the teeth. And the pressure on teeth probably puts load on the bone that keeps the bone stable. So it's pretty metabolically active, but at the same time, it does seem to concentrate some of the osteoporosis or those same drugs used at higher doses in cancer patients. And then you have a compromised region. So when it becomes extensive, it can lead to damage to the jaw. So, for example, you can end up with an infection that expresses outside on the skin. You can have open fistulas. Jaw fracture can occur. I mean, it is a challenge to manage. But in combination with the medical approach, which involves certain medications and intermittent antibiotics and some other oral care, light therapy may have a significant role. Those studies are yet to be completed or even initiated in many ways. The problem with studying some of these conditions like this one is the degree of severity and the difference between patients is so great that it's hard to get a uniform group together to do the study.
Right.
And right now the conditions are so challenging that pretty much, for example, why wouldn't you use light therapy in addition to the medications? It's hard enough to manage condition and to prevent progression, and hopefully even to lead to healing, that you just use those tools when they're available. And
you might not have the
home
study.
unit maybe makes that easier.
Yeah.
Because people can do it at home.
People can do it at home. They're not going to hurt themselves with it.
We have patients that have had bone exposure and symptoms for 6, 12, even 18 months, and then things resolve. And because the repair is so slow, even with all the interventions. So this can be a long-term problem. And that's where the oral probe that we've dealt with and you've developed and the red and infrared light seems to be really pretty critical, because there's depth of penetration that really matters. And you're still dealing with a compromised tissue that may or may not, have the even the viability to repair. But this gives people the best chance, and that's my view on the bone necrosis issues, regardless of whether it's radiation-induced, it's drug-induced at this point, and whether it's a cancer schedule of drug therapy or it's a osteoporosis.
Right. Well, it makes sense, even if you don't have the very specific study. I know that you're all about the specifics. You've kicked me into line to have to write my specifics down. But we do know there's 5,000 studies on how light therapy, photobiomodulation works. There's another 1,000 coming out every year, and it's probably going to get to 1,000 per quarter now.
Yeah. In my job as an editor for one of the supportive care cancer journals, and also for some photobiomodulation journals now, the numbers of new studies are really hard to keep up with. And as an editor, that means you have to review them. You have to have reviewers. The volume is remarkable. And so we will know more and more over time and be better at selecting, for example, who should get which therapy and who shouldn't. But right now, there are some well-documented conditions. One is the mucositis. The other ones we're learning about, but there's one other that we'll talk about in just a bit that's also in the cancer field.
Okay. Well, what I'm hoping people take away from this is, if you're not ready to be doing it in your own home, if you've got to have serious dental issues taken care of, or you're having head and neck radiation for cancer, take the step of finding oral care where your caregiver knows about laser therapy, light therapy, offering that photobiomodulation.
I agree with that. The issue is many cancer centers also don't have the professional units and are not set up to do that, and are not as aware of light therapy and mucositis as they should be. They will become over time. But if you can do this at home, with a home device, it would be so much easier, and we know the preventive effects that this has. So it's a bit of a challenge to know without the instruction where the light should be. But in typical cases, most head and neck cancer, for example, most cancers towards the back of the tongue, mouth, or throat. And so we know where the oncologist for sure knows where the radiation fields will be. And that's sort of the area you can look at. And typically that overlies or the radiation will expose adjacent tissues, meaning saliva glands too, which then become negatively affected and you don't make enough saliva. So while we don't have really great evidence of saliva effect in a radiation population, we have indications that may make a difference, but for sure we know it does in the mucositis. So you have two major acute and long-term symptom changes that can occur that this will address. The other thing is that we have prepared, and because there's more literature, there's more evidence of safety, and that is, imperative in a cancer population. But the evidence is, as we do more studies, the evidence is better and better, and there's still really no concern on the clinical side that this will, for example, protect the tumor. And there's biologic reasons why it probably doesn't. Right. There's animal studies that, depending on the animal you use, the cancer you use, the cancer therapy you use, and the light you use, it gets very confusing. So the literature, especially the older literature, is very difficult because energy levels, duration, and all that stuff sometimes isn't presented in the way it needs to be. So you almost have to eliminate the older literature. And even that, I'm talking 5 years ago. So it's really a new, I guess, field in that we've defined the parameters of the light therapy more tightly and more based on better evidence. And so when you start to do the clinical management schedule and dosing of red and infrared light, there's no evidence of tumor effect. In fact, it may even be the opposite. It may be a positive effect for the cancer therapy, but that'll take more proof. So right now, I think we're based on a very recent safety review in cancer patients. The evidence is supportive of use, and also because it has such a dramatic effect on mucositis. And there really is nothing else that's been shown to do that.
I would love to see a hormetic study. So you have a patient, they're scheduled for radiation chemo. As you said, you could pretty much guarantee we're going to see that oral mucositis. We're going to see the sores come up. So if they could, for 5 days a week, 10 days, however long they have before they're scheduled for that radiation and chemo, be using
start up front
the light at the back of the throat, in that area where they're going to be irradiated, to produce those protective results that we've seen in other areas, the hormetic effect. That would be fascinating to see if it did, if it helped to mitigate the level of problem.
We already know that if you start at the time of radiation, that we have a significant effect in mucositis. Starting before may be even better, but I don't think there's any good studies that have done that. Almost everybody starts the day of radiation. And also because many of the older studies were in hospital or in facility treatment units.
Sure.
When you get to the home field, you have a whole different opportunity. So home application may be very valuable. One thing we do know, though, and it's based on an animal study, but it's recent, is that if you give light therapy before the daily radiation treatment rather than after, there's more protection. So there's a diurnal variation, there's a time frame. So it looks like the best time to do it is before the radiation, like if you're going in the 10 o'clock, do it in the morning. Or do it when you first get to the hospital. So that I think is probably sufficient evidence to help us model that, because before that we thought, we didn't really know for sure if it mattered so much if you did it before or after, but it really looks like before is better. So we're learning that kind of stuff. And one other issue, I think the whole program is about pain, and I'm kind of not really talking about pain, but if you reduce mucositis, if you reduce bone damage and reduce ulcers, you're reducing pain. So in the cancer side of patients with radiation mucositis, there's typically lower use of analgesics, but it is either a direct analgesic effect or it's because the lesion isn't as bad. So in essence, we don't really care, but we don't really know either. But it doesn't really matter because
they never have gotten so bad that we didn't have to take so many drugs. But maybe we didn't. Maybe it just kept the pain levels down, right?
Yeah. So it may be because there's less activity because the lesion is less intense, less inflamed, smaller ulcers, or because it's actually truly giving you the analgesic effect in addition. So that could help us if that was teased out, but it doesn't matter clinically.
Right.
Okay. less
So the
pain
first,
and less
you just
lesion.
want less pain.
Yeah. So
Heal
it's,
faster, less
yeah. And the only reason patients care about it is it hurts. We as providers care about it because it may increase risk for secondary infection by having bigger, more damaged areas of tissue. So for example, in bone marrow transplant, which is the other population of cancer patients where we have sufficient evidence that the study group that writes some of these guidelines has recommended its use, is that other population in bone marrow transplant. So in that population, we are very concerned about infection because you take the bone marrow and basically get rid of it, try to kill the bad cells in the marrow, and then you replace it with marrow from some other source, and sometimes stored marrow of
right.
your own or someone else's. And during that time when there are no cells, infections really matter. And so as someone treating these people, we care more about the ulcer and the lesion, and the patient just cares how it feels. And
Sure.
it sort of comes together. But in the bone marrow transplant population, the other group that I mentioned that has mucositis with pain, that has systemic infection risk, this is a potential, again, huge opportunity. And those are often people in the hospital, but there are now outpatient bone marrow transplants done, which sounds a little odd, but you can do, for some people, you can see them in a surgery, an outpatient day facility every day and not admit them, which is an advantage for everybody if you can get away with it.
Sure. And in this day and age where people are not wanting to go to medical facilities because of the level of
Exactly.
infection there, if they can do whatever they do at home,
Yeah.
not have to. I know you and I I've helped one of your patients that was putting off going in to see you because she was terrified of being out in public due to for good reason. She has a compromised immune system. Going out and contracting COVID-19 would have been
Yeah, and
very,
the
very
COVID
dangerous.
world, yes, the COVID
And
world has changed us.
it has. It
Yeah. So,
has.
so the other, I just thought I would get into this. The other condition that's actually pretty common is oral lichen planus, which is a skin and or mouth condition that's autoimmune. So your own T cells interact with something that then leads them to cause inflammation and tissue damage in the mouth. And this, from my perspective, if you're a dermatologist, it causes it on the skin, and sometimes it causes it in both. So we have to learn to get along, which we do.
And what's the word again?
Lichen planus. It's really common. Now, some people have this low grade and needs no treatment at all. Doesn't need any steps for diagnosis because it doesn't progress. But it's like autoimmune diseases in general. There's a gamut, and some people are severely affected, and some people it fluctuates. So lichen planus, oral, has been studied very actively, especially in Brazil. And there's multiple randomized studies, the kind you want, to show effect, and it's highly effective. So in that setting, it's anti-inflammatory, again, and probably pain-relieving analgesic. And so based on that, we took a condition that occurs in bone marrow transplant patients and a few other instances, but not many. And what it is an inflammatory condition that's called graft versus host disease. So you have the graft, which is the transplant from someone else, even a relative, sister, brother, or someone you've not met. That's an unrelated donor. And what you're doing with the bone marrow is you're doing two main things. You're rescuing the person who's had super lethal chemotherapy to kill their cancer. So if we didn't have the ability to repopulate the bone marrow, it's fatal.
Yeah.
So that's why those are used. But there's another thing that the non-alike donors cells do is they mount this graft versus host disease, which originally was called that, but then it became realized that a little bit is a good thing, and then that term is called graft, and if it's leukemia, graft versus leukemia effect. In other words, the competent transplanted cells protect you from the cancer that you're treating. So there's two parts. There's the rescue, so you can make your own red cells and your own white cells and your own platelets for blood clotting. But there's the immune function that then recognizes the abnormal cells. But the but is that it can give you, as a host, as the patient who got the transplant, it can give you an autoimmune reaction, which looks like, acts like, and biologically at the cellular level and on biopsies is lichen planus. So
Interesting.
and that's called oral graft versus host disease. And that can be really challenging for some people. And while there's a raft of treatments, based around generalized immunosuppression, you never want to immunosuppress somebody more than you need to for obvious reasons. And the drugs that are used for that have side effects. So if the worst place of activity is the mouth, which are the ones I see, or sometimes the only place that remains when the other sites sort of settle, then we have to treat it locally. So one of the things that we use is we use all the same medicines that you can take by mouth if it's broadly spread disease, and you can rinse with it and hold it in your mouth, and we can put them into creams and gels, and we can control a number of patients, but we never had a really great outcome for everybody. In fact, the ones that are really bad are the hardest ones to treat. So out of a group of, I think it was 8 patients that we had here in Los Angeles, combined with some people, I think a group of, I think maybe only 3 patients, but in the Netherlands, we published the first case series looking at oral graft versus host disease and light therapy with really amazing results. So everything stays the same, and you added the light as a new device or a new therapy, and things changed dramatically. Most patients had less pain, like dramatically less pain, often no need for opioid analgesics anymore for pain or narcotics. Some could eat better, swallow better because of pain and scarring that occurs. And saliva was increased in some of those cases, which when it's autoimmune, as I'm mentioning, that sort of looks like Sjogren's syndrome, which is dry mouth as one of the manifestations. So we did that. We conducted a study where we looked at people weekly, and we did it for 4 weeks and reported those results. The next thing, we just kept treating people. And some people we had to continue longer because they were not fully resolved. And so then we tried to determine how infrequently could we see them. And that was using an in-office machine at the time. So, and then looking ahead, we ended up with groups of people, and this was 7 with the same Dutch group and us. This paper has been almost accepted. That's a great description. But it had a first revision where they asked for very little change. So it should be published quite soon. And we found that some people treatment every 2 months was enough. Some people, it was every 2 weeks for control. And if you went to less frequent light treatment than that, it would come back. And it's because the immune cells are still running throughout the body. If they weren't, you'd have something else wrong. And so they may come back to the same antigen recognition site causing a reaction. So getting back to that is exactly how lichen planus operates as well. But typically oral graft versus host disease involves broader areas of the mouth and is much more severe. And so this is a real advantage to patients. The next step is some of the patients have used home devices, and some have still been coming in because of the nature of all the other complications and drugs they're on and using the in-office based machine. So the obvious opportunity is people from a distance can do this at home and save the main side effect of treatment, which is travel and car volume, in especially, in a place like Los Angeles during the non-COVID period. So it's a tool that we're using for lesion management, oral soft tissues, autoimmune, direct trauma from radiation and chemotherapy, and for bone repair and other aspects of these complications that occur in cancer patients. And a lot of this is obviously driven by the need to manage pain better.
We lost you for part of that.
No, I thought I only lost you. But
no, I lost you and it came back. So
oh, great. I don't know where I was.
I don't know. We were talking about the
long-term use.
The long-term use.
Yeah. Okay. So I guess for people that have chronic conditions, which many of these are or become, if they're recurring, then we will try to find the least frequent schedule to treat. We also would rather patients, even if we're using topical anti-inflammatory medicines and other things in the mouth in the form of pain relievers in the form of rinse, we'd rather use light than medications, even topically. So the goal is to, manage the symptoms, manage the condition, and then withdraw whatever medications are on board that were used for that purpose to then rely on light as the primary modality, which we're doing.
I think it would be exciting if in a couple, within the next decade, anytime a patient was going to be facing one of these, it was just automatic that they were issued a home therapy device.
Yeah,
Where they could help. They wouldn't be all of it, but it would help manage the symptoms.
well, it may do more than you think. I guess I would say that some of these complications, you don't know what site of tissue they will occur at, whether it'll even be in the mouth, it might be on the skin. So you don't know where it will appear. In radiation therapy, you absolutely know where it's going to be.
Right.
So there's also both a meta-analysis done recently that I think is accepted. Yeah, it was accepted for publication. That wasn't a study or a report I was involved with, in use of red light for radiation dermatitis in breast cancer. So if you're receiving radiation therapy for breast, you know where, again, you know the fields, you know where it's going to be,
Right.
and you know the exact shape and size, actually, and that you can treat with light. Again, before the treatment makes the most sense. So the theme of anti-inflammatory effects in treatment complications is pretty well established, and so the advent of home units needs to be considered, especially maybe in relation to or in combination or instead of institutional-based treatments. Radiation therapists are generally pretty well set up to do this if they have the machine, because people come in before they're put in the treatment room, and that's an ideal time for the light therapy, and it's only typically a few minutes if you know the field. So if you step back and look at mucositis and mouth ulceration and pain in a transplant setting, you really don't know the sites, although typically it's towards the back of the throat. But at first sign of redness or discomfort or sensitivity, you can start the light then, and rather than wait until it's bad to try to improve recovery. But I think one of the big opportunities in light therapy is accelerating wound healing, meaning if you're giving someone, say, radiation therapy, which is sequential days of radiation for 6-7 weeks, or you're giving chemotherapy over 3 to 5 days or in cycles, then you're going to know where the previous lesion was, and you'll know where the light could be applied even before there's symptoms. So there's really nothing that we have available yet that will accelerate resolution of a lesion that we can predict. And that's in the mucositis, and obviously we don't treat graft versus host until you have it. But in any of those conditions that are repairing approaches, and this has real potential implications for use of light in those environments. So I'll give you an example. No studies that I've done, I'm not sure how many have been done actually, because typically what happens in research is you pick either the worst group or the one that's predictable. So in head and neck cancer therapy, if you don't get mucositis from radiation, we wonder if they even turned the machine on, that maybe they forgot, which clearly they don't. So that means probably 98% will have significant and oral changes, and when they don't, it's unusual. And you just wonder why not. But there's some molecular and genetic things that probably do that. And what was it? All right, what else am I going to say? Yeah, so in those settings, you can actually predict and you know where to go. Oh yeah, so if you have breast cancer or colon cancer or any cancer in which you're getting a cycled chemotherapy, say treatment every 2 weeks or every 3 weeks, if a condition that's inflammatory and painful arises, say, in the cycle before, it's almost always thought to be worse in the next cycle because the damage
It's already done.
is
Yeah.
cumulative.
Right.
So if you have a mild reaction, say in cycle 2 for breast cancer, and you've got 4 more cycles to go, then you know you want to start to initiate something as potentially preventative, and you know where your lesions had started. So those are the risk sites. So potentially in cycled chemotherapy, there's a real potential value. that remains to be documented, but theoretically it makes so much sense that it probably those studies might be an issue in the next little while.
Well, I know your specialty is the cancer and the recovery from cancer. I've had a couple questions that actually remind me of one of your patients that you sent to us who had to have like reconstructive surgery after a very bad car accident and had spent a lot of time trying to recover. And we've had people asking about that. Is there a benefit to using an in-mouth device? What have you seen in wound recovery that way and helping with the reconstructive surgery and that?
Yeah, I mean, based on literature of accelerating wound healing, and maybe by having the healing time, that's in cases that are very challenging like that, that's obviously a potential opportunity or value for the patient. Trauma and reconstruction can lead to vascular change and poor supply in some areas. That's one part of it. And so that's a big opportunity. And I actually think that we've discussed this as well, that there's an opportunity for this just in single tooth extraction, simple things, because why not reduce the pain and the swelling and speed the healing? So I think it's the same principle in those settings. And some of the injuries are very, very compromised, and they may actually have other things like free tissue grafts that are moved over with a new blood supply that you try to attach. So if you're looking at that and improving vascularity and again pain relief, but also speeding wound healing, that's the things that I think that's where this could be utilized, and I think there's opportunities there for patients and for research.
Good. Good. Yeah, I'm really surprised actually that my focus has changed so much over the last couple of years to include so much in the way of dentistry. As you know, dentists have never been my favorites. I'm not good at
but maybe if you had this when you were younger and you had your surgery then, you wouldn't have minded so much.
Maybe that's what has taught me a lot. But I think that it's one of the more exciting areas. We've been discussing empowering patients in India, in Singapore, in other areas, and I don't know if it's the dentists are more open to it. The dentists are they've been more exposed to it. Like you said, within the medical world, it's really that
it is, and that's North America. Yeah, and that's North America. Like for example, in Brazil, everybody knows about this. And I think every dentist has red light.
Wow.
And at least my experience has been that it's almost universal. And when you talk to people that are dentists from Brazil, for example, because that's some of the people I talk to, they know all about this. They actually, most of them have units. So the penetration there has to do with politics, meaning somebody said we need to get access to this for our patients or our population, licensing, and insurance. So in Brazil, I believe it is part of the standard approach. And so
we are still fighting the insurance industry on paying for red light therapy.
Right, and so that's what's led to Brazil being one of the centers of research, because they have access to machines, equipment, and patient awareness, and maybe going through other sources, meaning insurance.
I hadn't really thought about that, but certainly a lot of the research studies I see are coming out of Brazil.
Right, and once you're aware, like the public, then there's more demand, and it's all self-feeding. My estimate of what should happen in North America, and probably Western Europe, but their light therapy is more present, I guess, in the cancer centers. But it will be more present here if ASCO, the American Society for Clinical Oncology, gets through the process of endorsing the guidelines that I mentioned for mucositis management that have been approved and finalized through the Supportive Care in Cancer group. And while we, as that organization, creates guidance and creates recommendations and statements of guidance, the real two main groups in the United States that affect how everybody behaves are ASCO and the National Comprehensive Cancer Center Network, which is NCCN. The Organization of Supportive Care in Cancer has had I think 2 or 3 of our guidelines now endorsed or supported by ASCO, and these ones are being considered. So
Excellent.
at whatever time that occurs, it'll be common knowledge. Right now, it's sort of, if you read the literature, so for example, I mean, you have to go to either light literature or supportive care and cancer literature or mucositis literature, but if you're an oncologist looking at what's the next chemo, you're not looking at that stuff. So
Right.
it has to come from that different avenue, but the evidence is so compelling and that really can't be not endorsed. So it's just a matter of the process. And the process of endorsement of guidelines is complex and lengthy, even once it's approved by one of the bodies that works with ASCO and other things.
Sure.
So
Sure.
if it comes through there, there'll be a big change on the cancer side. There's already more on the musculoskeletal side. And then on as we were talking, on the dental side, meaning the general practice of dentistry, which includes extractions and other minor surgical procedures, that won't necessarily take longer because the understanding is there, but the evidence needs to be built that, if it reduces half the time, it makes your patients happier. And even if it's part of the cost of care, that doesn't matter if it does that. So quality of care matters. It's not just cost. Although if you're an insurance company, that has become, I think, debated. It shouldn't. It should be both. And I think this can do both in the right setting, the right condition, with the right protocols.
Well, we'll just keep after it, and I think that some of it will be market demand.
Oh yeah,
so
absolutely.
The more we have the general population see things like this, where they start learning what's out there, that is an option to opioids, it's an option to a longer, more painful healing process, they're going to start demanding that, and that's going to drive the market forces.
And an example of that, like I was saying, is Brazil. I mean, it's used maybe more than it should be. I don't know, but it can't hurt. So why wouldn't you? But I think the demand comes from both sides there, and there's general awareness. So it's a little different. But we're actually coming, I think, with light therapy from a position of really strong evidence for certain therapies, and increasingly strong evidence of safety, and especially in the cancer world. Whenever you protect a tissue, you think, well, man, I don't want to protect the tumor, because it's still the first job is to get rid of it. That's the tumor. So the evidence, again, is in head, neck, and in bone marrow, there is no evidence of protection that we can identify. And there's some molecular things that still need to be studied, but it's very, supportive of its use, not only based on that safety, but based on efficacy. So I think that's where we're at, and things are really growing. So.
And I think that's, the manufacturers are not ready to jump in and say, sure, you use my light therapy panel or my pads with your cancer. But I think they're getting closer to that feeling of safety, because the studies are coming more and more over the last 5 years. We've seen those studies.
Oh yeah, and I see them again as the journals I edit for. It's just rapid fire. But one of the problems with those studies, typically, especially ones from a while ago, are looking at cells in a cell culture.
Right.
And it's not that simple. People, the cells are in a body that has immune function and has blood supply and has surfaces. And if it's in your mouth or your colon, you've got bacteria on the surface, and the connective tissue interacts with the surface cells. And so to just take a surface cell, grow it in culture, and look what happens, it's not that simple. It gives you an indication that you maybe should look for certain things, but it is complicated. The studies need to be animal, in vivo, basically right now, and people.
And even the animal models, you're working with genetically identical, dietarily identical,
it's tough.
Rats, or they're all going to respond the same.
Potentially. And they're genetically, sometimes they're a genetic clone of each other, right? So
exactly.
so people have variable everything. And, that's why studies in people are harder. You can't give them, one kind of food for three weeks or 6 weeks for all of them, and the same dose and the same amount of water. It's not going to happen. And so one of the problems is when you do a study and then it gets into the broader community, sometimes it doesn't look as good as it used to. And you think, well, why not? And that's why. But I think The studies that look at individual cells are a real challenge because they're not in their normal environment. And so there's very little meaning there other than to say, well, we should look at that in people or in an animal model. So the animal model studies, which are now becoming more common, and then the human trials, because, for example, in Western Europe, in France and Belgium, they've got sufficient numbers to do clinical outcome trial studies and reports, and Brazil the same thing. So we are, and other countries, but we are getting that data. And all of the data in the last few years, which have been clinical human outcomes, have been very good. So we feel comfortable with the recommendation that the complication is severe enough and the safety is good enough that on balance you should be using this. Right. And that's how it always works as far as safety and risk benefit analysis. And that's
balance the two, right.
And cost benefit, it's that too. So if you have low cost, high benefit, and low to no risk, you really should be going for the benefit.
Even at $120,000 ultra premium full irradiation light therapy bed,
right.
You're left with, you start looking at that cost. I mean, not that I'm saying anybody should run out and go buy, or not. If it works for you, I've been told twice now that Tony Robbins has two immersion beds, but whatever, even if yours is a lamp, if yours is a $300 torch, $1,000 pad, a $5,000 full bodies, whatever it is, the cost of that versus being out of work an extra 6 months or being, is
and even just quality of life. So some of the things that still need to be done involve the potential light applications for cognitive function in cancer and in all of them. And there's the PTSD, you're probably talking about that. There's also the general potential for effect on general fatigue, and that follows cancer as well, and well-being and skin reactions that are broad and systemic. So the light beds will probably have a role, but again, we need those studies. It's just like we do for the CNS functions. And that has a huge potential need in not just the oncology field, but certainly there. And that's a little more focused and unique in some ways, but we create that all the time. So we could do preventive trials, we could do interventional trials, and those really need to be done because the needs are really massive, and hopefully that'll be happening.
Somebody asked me why there was so much research going on in the light therapy world, and I said, for one, you don't have the safety issues. So everybody wants to get into that. They don't have to wait so long to publish. They don't have as much safety problems. The cost of doing it is not as extensive. So why wouldn't you want to do research in something that's proven to have so many new benefits?
Yeah, and at the same time, one of the issues for oncologists is they are used to several phase 3 final stage drug trials of maybe, I'll pick a number, 3,000 patients that were randomized and followed over 2 or 3 years. And the studies cost lots of money because they're challenging and take lots of time. And then you have to go up against that because they're used to thinking that way. So that's why we need to keep doing the research, because we should anyway, but because they're a different kind of physician. That they are basically, if they were economists, they would be numbers driven, and they are. And that's important that they are, because what they have to do is pick the best therapy. Also, they look at the side effects, toxicities, and risks. And again, cancer therapy is full of risk, but cancer has a greater risk. And so you balance that off and you pick the best therapy with all of those considerations. But their data is much stronger. Having said that, you said, gee, look at all the studies. Look at all the studies in breast cancer, for example, that we have studied intensely for, 50 years, more than any other cancer. And there's still need for more. But boy, we know better about what to do because of that. So new therapies lead to new opportunities, lead to new outcomes that are better, but then there's the next phase. So we need to try and keep up on the research side as much as we can for all ethical good reasons. But in the oncology side, that's one of the reasons why you need that endorsement for a specific use, like with ASCO, because they are data driven. And there is enough data, we think, to to support the use. So that's why it was recommended, and ASCO's looking at those recommendations. So it's a little bit of a different mindset, because but also anybody that has devices versus drugs, yes, you have less intense data that you need to collect, but at the same time, if it's an oncology field, you have less data to use.
Right.
So it's all a balance there too. How much
And you have instant competitors. As soon as you
exactly?
have one mark on the market,
Absolutely. Yep.
it's going to be flooded with competitors,
Yep.
cheap knockoffs, crap knockoffs. It's going to be out there no matter what your device is.
Right. So that's, yeah. So you have to make the best device you can and make sure that you keep that up. And if the data is based on those particular devices, the ability to do that in an institution where you have committees that buy stuff, so that's why it takes so long, is real, because they will, excuse me, be driven by the data that drives the oncologist, that then drives the purchase.
Right.
But low cost at home approaches, I think, really need to be looked at in those settings in detail, because potentially that's maybe a better way to do it, especially when you know where and the site of treatment that you need to reach. And that's how we manage it here. Like I said, the main side effect of treatment is driving. And there's nothing that isn't half an hour away from you in LA, unless you're walking, and sometimes it's 5 or 10 minutes. But if you drive, it's half an hour. But if you're coming from 2.5 hours away, that's really tough. And so traffic has changed for the moment, but it's not going to be good for a long time. And that's good too, I guess. So
Yeah. Well, it'll be exciting next year when we revisit this after because you and I were working on a research study on home use devices.
yes.
And it'll just be exciting to see how this progresses, and we keep checking in with each other to see how things change over time.
And we do, and I'm happy to, actually.
All right.
Always good to talk to you.
You too, Joel. Thank you for spending an hour with me. It's great.